Hello, I am Catherine Orengo Gomez and I am a PGY2 from University of Illinois at Chicago Advocate Christ Medical Center. And today I would like to present a very interesting case about carcinoid heart disease and heart failure as the initial presentation. Patient is a 74-year female with past medical history of diabetes, hypertension, hyperlipidemia, COPD, and asthma, who came in with chief complaint of worsening exertional dyspnea for 6 months and 1 month history of diarrhea. On physical examination, her vital signs were stable, but she was very hypervolemic. She had bilateral lower extremity edema, crackles throughout her lungs, a GVD with prominent V-way, and a loud holosystolic murmur. Initial TTE showed a normal left ventricle function with ejection fraction of 50 to 55%, and she also had a TEE that showed moderate to severe right atrium and right valve dilatation with severe flail motion of septal leaflet and severe tricuspid regurgitation. She also had a right heart cath which showed very elevated filling pressures and a low cardiac output and cardiac index, so she was admitted to our ICU for aggressive diuresis and dobutamine drip for cardiogenic shock. Upon further investigation about why our patient was on cardiogenic shock, we were looking for infiltrative diseases that causes cardiomyopathies, including amyloidosis, sarcoidosis, hemochromatosis, etc. All these workup for infiltrative diseases were negative. So we obtained an MRI of her abdomen, which interestingly showed a mass in the liver, which was very suggestive of metastasis. And at this point, we had to think about carcinoid disease. Patients with neuroendocrine tumors produces very high quantity of serotonin, and this tumor product can reach the right side of the heart by the inferior vena cava and damage the valves. Our patient had very elevated serum serotonin, urinary 5-hydroxyindole acetic acid, and chromogranin A. So she was started on octreotide for symptomatic relief, and unfortunately our patient was in a very critical condition to go further treatment, which in a stable patient will have been valve replacement. Here at the bottom you can see the picture of the biopsy showing the neuroendocrine tumor. Carcinoid disease has clinical features including vasomotor symptoms like flushing, secretory diarrhea, bronchospasm, and hypotension. Patients with carcinoid heart disease, 20 of them will present with vague symptoms like exertional dyspnea, which sometimes can be attributed to other medical problems. Characteristics of carcinoid heart disease include early symptoms of right-sided valvular disease, including fatigue and dyspnea upon exertion, peripheral edema, ascites, hepatomegaly, elevated GVP with prominent V-way, and loud holosystolic murmur. Echocardiography findings show a pattern of right ventricle volume overload with enlarged right ventricle and tricuspid valve leaflet thickening, retractive valve with impaired mobility of the valves, leading to regurgitation and or stenosis. Interesting, the left side of the heart is usually spared because the lungs metabolize the vasoactive substances like serotonin before reaching the left-sided heart valves. Early detection of carcinoid heart disease can improve prognosis and symptoms in patients with heart valve involvement. Treatment is mainly focused for symptomatic relief with somatostatin analogs, telotristat therapy, and temporary diuretic therapy with definitive surgical valve replacement. To summarize, the intake message I would like to pass on is that every time we have a patient with right-sided heart failure, we have to make sure that carcinoid heart disease is included in our differential diagnosis. I would like to thank you all for your time, and mostly ACP and the community of Illinois Northern Chapter for organizing this event and listening to my interesting case today.